Good afternoon, one and all. Welcome to the webinar series of Vijaya Diagnostic Center. Today's topic is testicular biopsy interpretation and clinical implication. Testicular biopsy was considered as cornerstone for the male infertility diagnosis for many years. The recent guidelines for the male infertility have limited the indication for a diagnostic testicular biopsy for confirmation of obstructive azoospermia in men with normal size of testis and normal reproductive hormones. Most of the biopsies are performed in men with non-obstructive azoospermia to be used for the intracytoplasmic sperm injections. So, to keep us update on the testicular biopsy indications and its interpretation and clinical implication, today we have with us Dr. Kalyan A. Rao. Dr. Kalyan A. Rao has done his MD pathology from Kakatiya Medical College, Warangal. He has more than 2.5 years of experience in histopathology. He is the youngest and enthusiastic consultant of our department. Without taking any time, I will hand over to the Dr. Kalyan to go through the testicular biopsy. Dr. Kalyan.
Thank you for the kind introduction. So, without much ado, let us start the session. So, male infertility affects about 30 to 40% of men with abnormal semen parameters such as oligo or severely low sperm counts or completely absent sperm counts, which is called azoospermia. So, possible explanations could include environmental pollution, genetic factors, which cause an endocrine disruption of the gonadal development during the early pregnancy. And this, in turn, causes testicular dysgenesis, culminating in infertility, hypogonadism, and increased risk of testicular cancer. So, testicular biopsy forms a vital role in the diagnosis and management of unexplained male infertility. Testicular biopsy confirms a disturbance of spermatogenesis in men with oligozoospermia and elevated FSH or follicular stimulating hormone. It has a distinctive role in diagnosing obstructive azoospermia, which can lead to surgical repair of the genital tract, thereby resulting in the presence of spermatozoa in the semen, which ultimately leads to spontaneous pregnancies. In cases of non-obstructive severe oligozoospermia and non-obstructive azoospermia or NOA, testicular biopsy is performed for testicular sperm extraction or TESI, which is then used in various procedures of in vitro fertilization, such as intracytoplasmic sperm injection or ICSI. So, what are the causes of male infertility? It can be broadly classified into three categories: pre-testicular, testicular, and post-testicular. Pre-testicular causes are extragonadal endocrine disorders, that is, endocrine disorders outside the testis, maybe from the hypothalamus or the hypophysis. That leads to the aberrant hormonal stimulation or suppression of the testis, which ultimately leads to abnormal spermatogenesis. Testicular reasons could be primary testicular defects, which are either congenital or acquired or secondary. Secondary causes can be because of environmental insults or other diseases such as granulomatous infections or chronic viral orchitis. Post-testicular causes, most common and the most important is obstruction. Any obstruction to the outflow of spermatozoa in the semen. And this could include epididymis, vas deferens, ejaculatory duct, and ultimately the urethra. So, what are the indications of testicular biopsy? They can be broadly grouped into diagnostic and therapeutic. Diagnostic indications, the most important and commonly the common indication is obstructive azoospermia. Now, biopsy here is important to confirm the presence of normal spermatogenesis before surgical correction of the obstruction is carried out. Other indication is diagnosis of germ cell neoplasia in situ or GCNIS of testis, which was previously called carcinoma in situ of testis. Now, in certain conditions, this GCNIS is shown to be occurring more commonly. Such conditions are where the person has had a history of cryptorchidism, a history of testicular germ cell tumor previously, idiopathic testicular atrophy, testicular microlithiasis as seen on ultrasonography, inhomogeneous testicular parenchyma as seen on ultrasonography, and radiologically apparent solid testicular lesions. So what are the therapeutic indications? That is non-obstructive azoospermia or NOA. Here, the only importance of biopsy is to take out or harvest the sperms which are there in the testis and which are not there in the semen, because there is no sperms in the semen. And this is used for the purpose of IVF. So, this could be either by sperm extraction or by microdissection. Now, a note has to be made here that a part of the biopsy here should be used for histopathological examination to predict the chance of future successful sperm harvesting and also to pick any focus of GCNIS if present. So, how to handle the specimen and how it is processed. So, the value of a testicular biopsy is directly proportional to the way the specimen is handled by the clinician and then how it is interpreted by the pathologist. Ideally, a 3 to 3 into 3 millimeter aggregate of testicular tissue is recommended for processing. The surgeon should drop the tissue directly from the scissors or forceps into a fixative receptacle to avoid much crushing artifact. It is recommended to use Bowen solution, steel solution, or acetic acid zinc formalin instead of the routine neutral buffer formalin, as the latter causes shrinkage artifacts and luminal sloughing of cells, which can obscure the cell lineages inside the seminiferous tubule. However, a part of the biopsy can be sent in NBF wherever there is high suspicion of detecting GCNIS, as IHC markers are they come out well with fixation with neutral buffered formalin than with the other special fixatives. The commonly used marker here is OCT3 by 4. So these are three figures, three pictures. The one on the extreme left is a normal seminiferous tubule which has been fixed in Bowen solution. As you can make out, the contours of the tubule are totally smooth, uniform. There is the lumen is empty, and all the lineages are perfectly aligned because there has been no fixation artifact here. The one in the center, the lumen, first of the lumen shows sloughing of cells. Thereby, the normal lineage is disrupted, and the tubule is also infolded. So some amount of shrinkage artifact is there because this was preserved in neutral buffered form. The one on the extreme right is an example of irregular tubular outlines of crush artifacts. So handling the sample is also very important. A word on the normal spermatogenesis and histology. So this is a cross section of a seminiferous tubule. As you can make out, there is the outer wall beneath which there is a layer of small cells with lightly stained nucleus, supporting cells of the seminiferous tubules. They also secrete the follicular stimulating hormone. These are the Sertoli cells. The next in line are the dark and light stained cells, which are the first layer of germ cells called the spermatogonia. They are usually divided into spermatogonia A and B morphologically. They in turn give rise to primary spermatocytes, then to the secondary spermatocytes, immature spermatids, mature spermatids, and ultimately the spermatozoa or sperms. Now, in practice, three lineages are most apparent under the microscope compared to all the other lineages. They are coming from the tubule wall to the lumen, the primary spermatocytes, the immature spermatids, and the mature spermatids. And based on the location of these three lineages in the tubule, a pathologist can assess if the spermatogenesis is going in order or is there any disorder, is there any hypospermatogenesis or anything else. So basically, these three compartments have to be gauged when looking under the microscope. This is an HND picture of the same. You can make out that the very lightly stained nuclei towards the periphery, just beneath the tubule wall, are the Sertoli cells. Next, the darkly stained large nuclei are of the spermatogonia, the primary spermatocytes. I'm sorry. Then come the smaller, lighter ones, the immature spermatids. The small dot-like ones are the mature spermatids, and it's difficult to distinguish the mature sperms or spermatozoa from the mature spermatids. So this is a normal seminiferous tubule, so showing normal spermatogenesis. This is a cross section of multiple seminiferous tubules, and here you can make out the interstitial space between the tubules, showing certain eosinophilically present cells with eosinophilic cytoplasm. So those are the leading cells which secrete luteinizing hormone or LH. So what are the patterns of spermatogenesis? The first common pattern is of normal testicular biopsy. That is, the tubules show complete spermatogenesis with normal intertubular tissue or the leading cell population. So this is most commonly seen in cases of post-testicular causes of azoospermia, that is in case of obstruction, where the testis is totally normal, but because of obstruction, physical obstruction, spermatozoa are not found in the ejaculate. The second common picture is of hypospermatogenesis, where the tubules show all the stages of spermatogenesis, but they are reduced to varying degrees. So this commonly includes a mixed pattern where one tubule might show normal spermatogenesis, one would show hypospermatogenesis, and one might not show any germ cells, which is called Sertoli syndrome. So the mixed pattern is very commonly seen. 79% of such cases show success with microtessi in retrieving sperms. So it has very good prognosis in terms of assisted reproductive techniques. Causes of hypospermatogenesis include hyperprolactinemia, diabetes, undescended testes, varicocele infectious orchitis, which includes granulomatous orchitis and viral orchitis, irradiation, cirrhosis, alcohol abuse, cyclophosphamide treatment, methotrexate treatment, and pesticide toxicity. The next picture is of maturation arrest. Here, all the seminiferous tubules show complete arrest, developmental arrest of the germ cells at a particular stage. The most common is at an early stage, which is called early maturation arrest, and usually involves at the level of primary spermatocyte or spermatogonia. This is a more common picture, and in these cases, the rate of sperm retrieval is pretty low, about 14%. However, the less common picture of late maturation arrest, where arrest occurs at the level of secondary spermatocyte or immature spermatids, obviously, because it is late, the germ cells are pretty much developed compared to the previous picture. And here the sperm retrieval rate is satisfactory, 46%. The causes of maturation arrest are gonadotropin insufficiency, chemotherapy or radiotherapy, heat, infections, hormonal factors, nutritional factors, and chromosomal anomalies in either somatic or germ cells. Next, we come to the distinguishing feature, which is Sertoli cell-only syndrome. Now, here the tubules are of smaller caliber, they are sort of atrophied, and they show only the Sertoli cells in the tubules. Complete absence of germ cells is the criteria seen here. However, recent studies have shown that multiple biopsies or microdissection of the testis have been able to pick certain pockets of normal spermatogenesis inside such testis where Sertoli cell-only syndrome has been diagnosed. And if such pockets are found, the patient is prescribed FSH, and by the stimulation of FSH, the spermatogenesis is actually increased. Thereby, a rebiopsy is done where the sperms are picked up and used for in vitro fertilization. So, in such cases, from a very abysmal rate of sperm retrieval, it has gone up to even 45% success rate after stimulation with FSH. However, Sertoli cell-only syndrome can increase the risk of developing solid nodules inside the testis by 26%, which can show GCNIS. And there is an increased risk of testicular malignancy by about 10.5%. Causes of Sertoli cell-only syndrome, it is mostly unknown or idiopathic. Then Klinefelter syndrome with 47XYY genotype. Exposure to chemicals or toxins, hormonal therapy for prostatic carcinoma, viral orchitis, irradiation, and congenital factors such as microdeletions of Y chromosome. Last picture, which is comparatively rare, is of seminiferous tubule hyalinization. So here there is thickening of the tubular and peritubular membranes due to fibrosis and deposition of basement membrane like pinkish material, as you can see in this picture. So as the tubules are completely atrophic and sclerosed, there is complete absence of both the germ cells and the Sertoli cells. However, the interstitium is totally fine and can appear hyperplastic in comparison to the atrophied sclerosed tubules. So all these cells that you can see here outside this pinkish material are the normal leading cells. So it is also called end-stage testis or tubular sclerosis, and for obvious reasons, the sperm retrieval success rate is very poor. Causes of seminiferous tubule hyalinization are any ischemic condition, infections, idiopathic, and Klinefelter syndrome. Now, there is a mixed pattern seen in many cases of testicular biopsy, where one tubule, such as one here in the center, can show only a picture of Sertoli cell only, whereas the surrounding tubules show hypospermatogenesis. So, such mixed patterns are quite commonly seen. A word on germ cell neoplasia in situ. So, germ cell neoplasia in situ or GCNIS is neoplastic transformation of the germ cells within the tubules without any invasion. So, it is not a case of full-fledged carcinoma. The germ cells are neoplastic or about to be malignant. They are limited to the seminiferous, and this can be diagnosed histomorphologically and confirmed with IHC OCT 3/4. So it becomes very important to diagnose GCNIS in time so that the progression to carcinoma is prevented. So there are certain conditions where GCNIS is expected, such as germs and tumors already diagnosed in patients in adults can show foci of GCNIS around them. So whenever there is a testicular biopsy which shows GCNIS, it becomes imperative to investigate the patient for any focus of actual carcinoma. Next, 50% of patients with GCNIS develop invasive germ cell tumors within 5 years of initial diagnosis. Therefore, it becomes very important to pick a focus of GCNIS within time to prevent the progression to carcinoma. Then, in patients with a history of prior testicular germ cell tumor, 5% of contralateral testes can develop GCNIS and thereby carcinoma. And in less than 5% of cases of cryptorchid testis and less than 1% of patients with infertility can show foci of GCNIS. Now, how is the spermatogenesis evaluated? So the most commonly used score system, which is most popular also, is modified Johnsen scoring. So here, Johnsen scores use a 10-point scoring for quantifying spermatogenesis according to the profile of cells encountered along the seminiferous tubules. A Johnsen score of 10 indicates maximum spermatogenesis activity, whereas a score of 1 indicates complete absence of germ cells. To obtain the Johnsen score, slides are examined under an optical microscope, usually under the 100x and 400x magnification, and a score is assigned for each tubule counted. The number of tubules counted with is then multiplied by that score. And the result is summed across the scores and then divided by the number of evaluated tubules, giving the final Johnsen score. These are the different scores which can be given to each tubule that is assessed, ranging from complete intact spermatogenesis, which is 10, to completely absent germ cells and Sertoli cells, which is 1. So to conclude, testicular biopsies are performed for both diagnostic and therapeutic reasons. Diagnostic testicular biopsy helps to differentiate between obstructive and non-obstructive azoospermia in men who have complete absence of sperms in the semen with non-testicular volume and normal serum reproductive hormone levels. Testicular biopsy can detect germ cell neoplasia in situ in men with signs of dysgenesis on ultrasonography, which include inhomogeneous testicular architecture, testicular microlithiasis or small stones, and non-palpable solid testicular lesions. And in case of cryptorchidism, in early adults or adolescents. Therapeutic testicular biopsy forms the cornerstone of assisted reproductive technology, and accurate biopsy interpretation is critical in the reproductive prognosis of the patient. Thank you.
Thank you, Dr. Kalyan. It was very informative and very beautiful presentation. I just want to ask you one question. Routinely, how do you report your biopsy, testicular biopsy? Is there any protocol you follow to report the histopathology examination of testes?
Yes, ma'am. So we have developed a protocol. There is no prescribed protocol as such. So we see how the biopsy has been received. We prefer the biopsy to be received in buoyant solution, which we prepare ourselves in house. And after proper fixation and cutting, we check the number, how adequate the specimen is. Ideally, it should be 100 tubules per section. Though we have to report on any number of tubules that are present, 100 is the minimum ideal number to give a satisfactory report. And then each tubule is assessed using the Johnsen scoring. Each tubule is seen for the caliber of the tubule, thickening of the tubule. If thickening is there, we use some special stain to see if it is really thickening or something else. Then the germ cells are seen, if the lineage is normal, if the number is normal or not. The number of Sertoli cells come to the germ cells, the ratio germ cells to the leading cells, all these are to be assessed. And we also look for any focus of GCNIS, which should not be missed at all. Second most important thing, which is common in India, is granulosis. So any focus of granulomas should not be. So that's how we go, and then go to each tubule, and the way the Johnsen score was explained, we give a final diagnosis with the Johnsen score, final Johnsen score.
Okay, yes. Yeah, I think with this we can conclude that testicular biopsy is done for diagnostic as well as therapeutic purpose. Even if it is done for therapeutic purpose, the date of biopsy should be given for the histopathological examination to see the chances of, chances of success of the insemination, and to search for the GCNIS focus. So that is very, very important. I think we are not seeing any questions from the audience. So we'll conclude here. Thank you so much, Dr. Kalyan, for the nice session. Thank you. Excuse me, one question has come. What precautions should one take in transporting biopsy specimen? Dr. Kalyan?
Yeah.
Can you hear
So
me?
ideally, yes, I can hear, ma'am. Yeah, I think I'm unmuted now. So initially, whenever a biopsy is being sent, we would request the clinician to inform us prior, because buoyant solution is recommended as the transport and sedative medium. So if they don't have it, we can send it to branch wherever they are sending the sample. And just like a routine biopsy should be transported, there's no other issue with it. Only the transporting medium and the fixative has to be buoyant solution, because that is what we produce here.
Yes, and I think the biopsy should be directly transferred into the solution without any crushing artifacts. So that should not be with the forceps for longer time. It should be put into the buoyant solution as soon as they are taking out from the testis. So these are the precautions they should take at the time of taking biopsy and sending the biopsy to the lab. Oh, okay, thank you. No other questions, Dr. Kalyan. Thank you so much. Thank you so much for the beautiful session. Yeah.